out the shoulders, so a bit like we did with the back. So go over a bit about anatomy just to make some things a bit clearer, hopefully, about when to image and what we image, or what modality we use, what the common myths, common injuries, the general frequently asked questions I get, and as always, a little bit of safety just in case. So as I said, please just speak out if there are any questions. So back to the basics of the shoulder. So we have our clavicle. So it might be, if you can see me, I do a lot of talking with my hands. We've got the collarbone, so that's our clavicle, starts at our sternum and then attaches to the really bony point at the top. So that's called our acromioclavicular joint. And I'm really sorry, my picture's really blurred for words. We have the humerus, which is our big long bone, and not as funny as we seem to think. So that's a ball and socket joint. That's at our shoulder. We have our shoulder blade, so the scapula, and that sits at the back. Now that bony bit at the top that meets with your collarbone actually is your shoulder blade as well. So that what makes that really prominent point that we have nothing but skin that covers it. So most people can feel that if they track along their collarbone. We then have the ribs that go around, especially around this first rib that can link in with shoulders. And that is all of it. So they are the bones of the shoulder. Now the shoulder is a ball and socket, and it's a really shallow socket. So it's one of our most mobile joints for that reason. Muscles. So most people will know about the rotator cuff muscles. So there are 4 muscles, 3 attached to the front half of our humerus, and 1 attaches to the back. So all of the muscles of the rotator cuff actually sit on our shoulder blade. So either in front or behind. So you can see that on that picture on that left. But they all attach to the humerus, and the way they attach is to kind of what direction it can do. Now, these muscles are about stability. They're not big, powerful muscles. So your traps, your lats, and pecs, they are your big, powerful muscles. These are not going to do big movements. So it's more the little guiding and keeping things in the right place. So our shoulder as well. So if I go back one, our shoulder, as I said, is really shallow. So what it has is something called a labrum, which on that edge of that blue bit, I don't know if you can see my cursor, so where the ball of the humerus and the shoulder joint, you've got something called the labrum, which is like a suction cup, and that's its job, is to help that stability at that joint. So we have, you might have heard people say they've had slap tears, so labral tears, and that's normally with excessive force. So the most common ones I've seen in sport is kind of being tackled. So American football, rugby, where people are put into that big external rotation in that quick force. So main muscles. Then we have our big hench muscles. So like I said, these are the big game players. So when we're doing strength work, these are our most powerful ones and do the big movements. However, they're big and powerful, so sometimes that works in our favour, but also that can work against us if one muscle is more powerful than the other. So I'm not saying things are weak, it's just comparatively. So the picture on the left is the top layer. We've just taken away a layer, or we're looking at, actually no, we've got front and a back here. So the front, we're looking at our pecs, and what you can see, the pec goes underneath your collarbone and down your sternum. So that's kind of those 2 borders. It then is almost a bit like a triangle. It spins and like bundles up and attaches to the front of our humerus. So that's underneath that deltoid. Now with pecs, depending where your arm is to which fibers are working. So if you've got your arm up, it's going to go down to more those sternal fibers. If you've got your arm out to the side, it's going to go more on those clavicular fibers. So that is also factoring in when you're doing mobility. So some people have great mobility with their hand level with their shoulder, but their mobility is not as great, which is what will affect you more on overhead compared to some other movements. So it's just understanding what the anatomy looks like to why we stretch in different ways and why one person might be good at something compared to the other. At the back, we have our lats. So that's that big one at the back that you see kind of blends into white. So it goes into this like tendon sheath that attaches our back. And that's our big monkey muscle. So those big lat pull downs, as the name suggests, is bringing that arm back and down. Obviously, you can see on those pictures, you've got your deltoids. So that big muscle that sits over the top, you've got your anterior, the front, the lateral and the posterior, so it encompasses that shoulder joint. You can see on that left picture, we've also got our neck muscles. So that does play a big part. So when I said about how ribs can interact, so if you clench, so Sam's probably had this at me already, or I've had it done it to already, is when you clench your teeth, your neck muscles come in and that's what lifts up our first rib. So if you ever see when you're out of breath, you get these muscles, or someone that's in distress, these neck muscles, they're called accessory muscles, actually work really hard because it's trying to lift that first rib and give you space. If you've been running, you go into a tripod position because you're trying to lift that rib. Oh, that's amazing.
Sorry, that's me. I could dial in for a bit, so I'm here to join in.
Perfect. So we're just saying, so there's muscles of the neck. We've got our trap, so our trapezius goes from the back of our head to the top of our shoulder, so that acromioclavicular joint, and then down our back, so it looks like a cross. So depending which one is the most dominant is kind of where our shoulder is going to be taken. So a little bit of anatomy, and then I'll go back to kind of muscles are always the key players. So when I ask questions, when people do get arm, shoulder, neck pain, is we always check nerves. So underneath your big trap muscle, you've got a bundle of nerves called your brachial plexus. So that bundle is what then spreads out, and that's what affects what part of your arm. So the reason this picture, don't worry too much about it, that's a me problem, is that's why I'm really pedantic when I ask you, where are your symptoms? Where is your pain? Where is your tingling? Because that will determine which nerve could be affected. So if you're saying I'm getting tingling in my thumb and my index, that will relate to a certain nerve. So we'll know along the line what might be the culprit. Same with the neck. So depending when you see this C6, C7, don't worry too much about it. It's just certain nerves affect certain things. So say we talked about sciatic pain, so it has to be a certain nerve that's going to cause sciatic pain, because that's a certain nerve that most people know. However, in our arm, we've got our ulnar nerve that goes on the inside. So when you hit your funny bone and you feel that tingling into your little finger, that's actually your ulnar nerve. So not so funny about it. So these are the kind of things that I'll ask, because it's sometimes we get pain at our shoulder, but is it referral? Is it true mechanical shoulder pain? So again, that's why I ask these weird and wonderful questions, and that brings about the complexity of that shoulder complex. Any questions at the minute on just anatomy? Nope. So back to, again, it's all, I have very similar messages across all body parts. It's when to get an image, when is it actually going to change things? So shoulders are always a bit different to say backs. In primary care, so what I see a lot is people want ultrasound scan just to see what's going on for persistent shoulder pain. So the only time I would get an ultrasound is if we know that there's been a potential muscle tear or a cuff tear. So I got tackled, my arm went out this way, and now I've got pain. Or if someone is like lifting their arm up and they start doing cheats. So as I said, our rotator cuff are not big muscles. Your rotator cuff is not what lifts your arm up. One of your rotator cuff, its job is to get the first 20 degrees of your arm lifting, and then your big muscles carry on. So actually what I'll see is that people will hitch, they'll use their traps, because our body will always find a way of just getting on with it. So that is where the cuff can be hidden sometimes because other muscles start to take over. Sometimes it can be really blatantly obvious if a cuff is gone. Around shoulders as well, because appreciating strongman, not quite shoulder, but things like bicep ruptures. So if I see a clear, we've all seen it, like the loud pop, then you get a big Popeye sign because it's just detached. That's where, if in doubt, go A&E at those points, because that needs a quick intervention, because there's only so long before we can't retract that muscle back up. But ultrasounds generally, when I get these kind of progressive onset shoulder pains, an ultrasound won't tell me anything, or it won't tell me anything I don't know. So I'll know that there'll be a tendinopathy and what they call a bursitis. So in our shoulder joint, we've got the ball and socket. At the edge, so that outside edge, you've got something called a bursa. So it's a blister pack, and when you lift your arm up, it should tuck in nicely, and it stops the muscles on the top of that ball and socket of that ball hitting that top. Now, if for any reason it's aggravated, so a lot of kind of overhead pressing can irritate it, losing my teeth. When you lift up, it's not tucking in as nicely. So most people say it hurts when I lift my arm to the side. It hurts when I get my hand behind my head or putting my coat on. And most people say my pain is out here. And it's, again, this is irritated. Now, our ultrasound won't change anything. It will just tell you that it's there. X-rays. The reason I do x-rays is if we've had trauma. So I have fallen out onto my arm. So what we call a foosh, fall onto an outstretched hand. So it could be that you've fallen that way onto the floor, but most commonly, especially in the sport, falling and putting your arms out, and that's where we can get these fractures at this collarbone, but then sometimes at the top of the humerus where it hits that point there. And after dislocation, so even if we do a realignment of a shoulder, I'll always get an x-ray, because if it's come out, it's just checking that nothing is fractured. So if ever you've had dislocations, always get it checked to make sure, one, it's in the right place, and two, there's been no damage on the way out. MRI, again, we don't do it that regularly unless we're considering surgery or we're considering a labral tear, so this little suction cup. And when we do an MRI of the shoulder, we use what we call an arthrogram, meaning you have an injection into your shoulder, so it basically lights up certain structures, but it's called an MRA. So as I said, it's only if we're looking kind of labral, that's when we'll do it, but it's more the mechanism that will tell me what image I want and if I want it. Any questions on that? So one thing to point out, and it'll come up more on safety later, it's a lot of things that I end up having to rule out is there's no other pathology that might be causing shoulder pain. So I'll always ask, have you had any shortness of breath, any productive cough? So the lovely stuff, the coloured phlegm. Have you been exposed to asbestos or potential? Are you a smoker? Have you got lumps and bumps around kind of breast and armpit? And that's men and women. Have you got kind of persistent pain? It doesn't matter what position you're in. It's kind of this really general around here. That's where I might consider a chest x-ray. So it's just ruling out the nasties, and not saying that I see it that often, but things like what we call space occupying lesions, so kind of tumours that sit in that space underneath the collarbone. If we're looking at lung cancer, breast cancer, secondary cancers, so that's where I'll ask about kind of medical history as well. Again, it's always just being aware that I'm not being nosy. That's what could be happening around that area. And then also things like ovaries can refer up to shoulder. But again, if you tell me I fell or I did a press and got shoulder pain, it's unlikely your ovary that's a problem. However, it's just giving you that whole picture of what we kind of rule in, rule out. So common shoulder injuries. So if I go back to the shoulder is the most mobile joint, it does lots, therefore it's got lots of opportunities to get annoyed. So most common thing that people come to me is this progressive onset kind of shoulder pain. Most people will point to the front or point to the side. It's normally like start of and I always say normally, this is never one size fits all, but a blanket kind of what I'll see of shoulders, probably 90% of my clinical career. This subacromial pain. So the acromion is listed as that ball and socket. Anything getting annoyed in that space, that is this umbrella term. I don't like to say, is your supraspinatus, it is this, because I haven't got MRI vision, but given if you tell me it's here versus here versus here, I've got an idea, and we're going to manage it the same. As I've said in many presentations now, it's like having a blister. If you annoy it, it will get angry. Just because you've stopped that press, it's not going to go away like a blister on your foot. Just because your shoe's off, it's not going to stop. You have to stop annoying it, and then it'll get better. So we started off I'll go back to, I can be David Attenborough now. We can go back to evolution. We started off in the fetal position. So very pet dominant, curled up in a ball. you can see evolution. So we started off hunched over creatures and we've evolved to stand up straight. Now, I'm sure we can all recognise as a population, we're devolving now because we're on computers, we're driving, we're not as manual creatures. Yes, we're the athletic population, but as a general, we're not doing as much lifting as in our previous years. So our chest muscles are becoming more dominant. So if we go back to Da Vinci's painting of the anatomical man, you see it's a person with their palms up. That is the anatomical position. That's our most efficient position. We have evolved and we start to come in. Our chest gets tight, and you can see here on this ball and socket, hopefully you can see a video me speaking at the minute. Our shoulder, the ball and socket, all our tendons come through here. So when I'm moving, it can move freely, but if it's getting tighter for whatever reason, closer space, that's where things get annoyed. Now, if we're starting to turn inwards as well, that is where we're closing that space and put it more susceptible to be annoyed. So you can probably still move, it hurts, but you can do it. So this is where you'll hear me bang on a lot about doing more pull versus push. So we've had to spend time and effort to evolve into using our posterior chain. And as I said, our anterior chain has brought us this way. So there's like boxer stance. So pull exercises is literally, as the name says, anything where you're pulling, pushing anything in whatever direction. And that's where things like bench, it might be that we change the direction of the push. So when I went back to my original on what a pec looks like, because that can change our symptoms. So as I said, with this SAP, this subacromial pain, it's generally an overuse injury. There's not a clear, I fell on my arm and it hurt. So they'll say it kind of came on over time. I was aware of it when I was doing press sessions, and now I'm aware of it when I sleep. I don't like putting my hand behind my head, dressing, put my bra on. That's the kind of things that I'll hear. So most of the time, again, nearly all the time, it's rehab management. So we have to look at the cause. It's no point just treating the symptoms. So it's all well and good, we loosen this off, but why is it getting tight? So later on, kind of one of my main things is, gym is not always the main culprit. If you sit at a desk like this, and then you're in bed like this, and then you drive like this, that is probably more of your hours per day than doing the 20 presses that Chloe's prescribed you. So think about the big picture. Next slide. So the other less common pathologies that I would say in the sporting population, that SAPS is the bread and butter. I would say 90% of what I see. A frozen shoulder, you might have heard about this before, is that labrum, that suction cup. It's called the capsule, gets adhesive. So another name for it is adhesive capsulitis. Now, there's no clear kind of reason why people get it. Sometimes they say people with diabetes have a higher chance of getting it. Now, what happens is this capsule gets more thickened, and this process has 3 phases. So it freezes, so people lose range of movement and generally have quite a bit in this pain in this phase. It's then frozen, so they've lost range of movement, but generally it's not very painful. And the most common things they lose is external rotation and kind of that end of range overhead. The last phase is it's thawing, and that's where we can get a bit of pain again, and that's where we're actually getting that movement back. Now, this can take months to go through all these phases, so it's not an easy one. Once you've diagnosed with this process, it's unfortunately one we have to ride out, and we haven't actually found much of like how to stop it or how to get it to go any quicker. The key part is trying to get movement as you can, but not into pain. So people that are freezing or in that frozen phase, there's no point thinking, I'm going to keep going and going, because actually you're going to irritate it more. I put a little picture of an injection. So it's when to inject. So the only time I would consider doing steroid injections is with frozen shoulder. If pain is so bad and pain relief orally isn't affecting it, that's when I might, but it won't change this freezing, frozen, thawing process. It's purely as a pain management. With the shoulder, the SAPS, I'll only do it when pain is limiting the ability to rehab. it is not the fix. And that's what a lot of people think, it's the magic golden drug. But actually, like I said before, if we're not addressing the problem, I can inject my blister on my foot, but if my shoe's not coming off, it's not getting better. So actually, shoulder injections is probably the highest failing injection, because actually it's the homework that needs to be done, and this is just a window. Muscle related or kind of nerve pain, so we can get people that come in to me and they say, I've got shoulder pain, but that's where I'll ask all these questions. So where is it exactly? Oh, it's kind of going down my arm, or it's going up into my neck, it's going down to my thumb. So that kind of tells me a lot. It's unlikely the shoulder joint, but actually we're looking more at this nerve type pain. So if muscles around, say, the traps and around the neck get affected for whatever reason, so it could be that's why you're feeling pain at your shoulder, because that's where the nerve is getting annoyed. But the fact you're getting pain down that arm shows I'm not looking at like a bony structure around the shoulder, I'm actually looking a bit higher up. So pain can be, and that's where I'll ask, like, what's the nature of the pain? So is it sharp, dull, toothache, burning, tingling, numbness? And when we say numbness, is it completely numb, so I do this and I could burn myself and not notice, or it's just it feels like a dead arm? So lots of probing questions that can sometimes guide us to what structure is being annoyed. And the big thing, and again, safety as always, is if you're getting these symptoms, one arm, not too worried. Both arms at the same time, that definitely needs to be assessed, because we're looking higher up the neck, as opposed to if it's one arm, we're more likely dealing with this end as opposed to actually in the center. Now, osteoarthritis, so we can get osteoarthritis in the ball and socket, but also at that acromioclavicular joint. Lower occurrence compared to like hips, knees, that's obviously where we hear about it a lot more. Shoulders, not so much, unless there's been kind of trauma in the past. So previous surgeries, fractures, and that's why, again, these probing questions about history, because that'll give me a better idea if there's a chance. Again, x-ray doesn't change too much unless we're getting to a point we're looking at surgery. Again, that pathway, so surgery for shoulder OA, actually it's only going to do a reverse replacement and you lose a lot of function, so it's only for pain. So a bit like a knee, people think that's their new kind of outlook, whereas shoulder, I say to them, it has to be that everything is so bad it can't get worse, so pain is just so overwhelming that you're happy to lose, that you're not going to have any over shoulder range. So pain relief, so I'm just checking that I've not missed anything. Yeah, so pain relief, it's all well and good, but most of the time we just need to have a look at the cause. Any questions? I appreciate I've talked a lot about lots of things. So the general questions, so why do I get knots? So a lot of the time muscles get tight. So especially, as I said, these trap muscles, they get tight, and most of the time it's all well and good that muscles get tight, but we need to have a look at the why. We can keep loosening things off, but if we're not looking back one step of why they're getting tight in the first place, we're always going to be in this revolving cycle of being reactive as opposed to proactive. Now, back to what I said earlier, trap muscles, your appraises, is a posture muscle. Your head is the heaviest part of your body. So if we have our kind of head neatly stacked, it's the least weight you have to deal with. Anything where we start to move forward, it's something like every millimeter forward is an extra 10 pounds of weight that your neck muscles have to manage. So it's not that our necks can't manage it. So if I were to hold my bicep curl, I can hold it there. But if I do that for 6 hours, for example, sitting at a desk like this, yeah, it's going to be a lot more painful than if I hold it there for 5 minutes. So that's why we do go about posture. Now, there's never the perfect posture. You know, we're told to sit like so, have a book on our head, but actually our body won't like that for 4 hours straight. It won't like this for 4 hours straight. We are designed to move. That's the kind of creatures we are. Now, especially what we call cervicogenic headache, so where that muscle goes to the back of your head and it can sometimes go almost feel like over your scalp. A lot of the time, and this is what shoulders and necks, especially when I say shoulder, are probably looking at this outside of your neck side as opposed to a true shoulder joint. Most of the time, as I said, it's going to be posture. it's going to be things like stress. So if we get stressed, we go into like shoulders towards our ears, we clench our jaw, and that's where you can see people where you tell them just to woosah. And that's these muscles, you're making them work harder. And actually, I'll ask a lot of people, you know, do you know if you grind your teeth? Ask your partner, they'll probably tell you more. Some people have bite guards because if you are clenching down, these muscles work really hard. If you get to a point, even like chewing meat, you feel it, it's because they're overworking. So it's just being mindful that probably things like stress, posture, and that's that note at the bottom. Think about the big picture. It's don't blame it on that hour in the gym. Think about the rest of life. So what are you doing in your spare time? So some people that are on PlayStations, is it when we do have kids, we're doing a lot of where we're bending down because they're smaller creatures. So do we need to look at how can we change what we do to help ourselves as opposed to just blaming it on the gym? Probably more from like the coach's perspective. So our rotator cuff are small muscles, like I said at the beginning. So when we're doing accessories or when you're programmed accessories, you have to focus on what is the intent of the exercise. It's being slow and controlled, and that these big muscles aren't going to take over. So when you're doing like almost the external rotations, anything like stability, I wouldn't expect big heavy muscles. So like anything external rotation, if you're going into double figures, are you truly using your rotator cuff, or are your bigger muscles going to get involved? So that is where think about what is the intent of the exercise. So the accessories generally aren't about adding big muscles. So like your big 1 rep max press, you will be using those big muscles. So have a think about that. Do film yourself. What can you see? Can you see that we're starting to get trap city, or are we able to keep shoulders back and down? So when you're doing like scat pull-ups, have you actually got nice control, or are you starting to use alternate muscles? So we go back to the basics. If we do a deadlift, when you're at that 1 rep max, you use anything you can. Okay, so when in certain exercises, when do you need to be in perfect form? So back to putting the pieces together. As I said, I repeat myself a lot, but it's because we've got to keep it simple. So it's making sure we look at our recovery. And this is where Chloe and Emma are really good at more the mindfulness. So when we look at the recovery wheel, kind of that reflection, that mental side of it, of actually calming the system. Our body, what I said about in recovery, is all about fight or flight or rest and digest. So kind of our neck and our head muscles, that is where there are a lot more of that sympathetic nervous system. So what can we do to calm things down? So it's having these check-ins about dropping your shoulders, relaxing your jaw. When you're at your desk, like have a cue. So if you get an email, just think about your position. So for example, if I'm doing assignment work, I'll end up with my nose on the screen and then have to kind of like push myself back and then carry on. So it's not bad. It's just I've got myself a strategy to stop myself being in there for prolonged positions. When you're driving, every time you see a sign, have a wiggle, don't, you know, as road legal allows, actually get moving. So even if it is just some shoulder rolls, is it just change your position slightly? Again, is it think about how to relax that jaw? If you're in a meeting, so if something happens, find your normal triggers. Oh, sorry, power low. Find normal triggers to give yourself those cues. You'll get to a point you're like, oh, I'm there already. But if we're getting stressed, it's having that awareness, but doing those quick things that you know would work for you. So obviously we've got the shoulder self-check that there's a video as well going through what to do, like the kind of solutions. But I think the kind of mindfulness, and I'm sure Chloe will be able to tell me if there are more resources. I believe Ellis did a session of how can we get things to calm down, and that's sometimes more powerful than actually doing more exercise, more rehab. Sometimes less is more. I said about this before, I've always got to do safety police. So when we talk about shoulders, it's always being mindful. If you get shortness of breath, Pain is there all the time, so it's not mechanical, meaning when I lift my arm up, it hurts, but when I leave it alone, it gets better. If you've got a productive cough, so coloured phlegm, greens, yellows, blood especially, if you are a smoker, if you've had previous cancers, family history of lung, breast, or previously being exposed to asbestos, if you're getting a persistent shoulder pain, definitely get that checked out. So I'm not saying, oh, I've had pain in the gym for a week, I must get this checked out. It's just if it's persisting, these are the things I'll always look into as well. Again, that doesn't stop you just asking me the question. I'm more than happy to reassure. It's not likely going to be this, but I'd rather you know and not need it. So that is it. So let me stop sharing. Stop video, next. Sorry. There we go, stop sharing. All right, hit me.
I'll start. I had shoulder surgery a bunch of years ago, a slap tear and some minor rotator cuff repair. And since then, it's always been a little bit weaker, which it just is. I'm working on it. Chloe's helping. But it always gets really, really knotty. Like I always end up having just giant knots across my tricep and in my shoulder, and it's limiting the mobility. And is that common, or am I just need to?
No, and that's where you hit the nail on the head before. If muscles are weaker, they're going to get tighter quicker because say that the other arm can tolerate more.
Mhm.
So our body will always find a way of getting on with it. So especially with pressing, you could easily go 60-40%. So your dominant arm or your kind of non-injured arm can take most of the brunt. Now, if I got you to do it dumbbells, it might be a completely different story. Like one arm's like bam, and the other one's like, oh, I'm coming, like the Nemo arm. And that's where, depending where you are in your kind of training cycle. So I'll say to Chloe, for some people, let's do more single arm, single leg work. So again, it's very similar, upper and lower limb. If there's knots, it just means it's not quite tolerating what the demand is. And the hard part with shoulders as well is we generally have a very dominant side. So actually, that's probably what I missed earlier. So be mindful, especially in strongman. We do a lot of single arm stuff. So how many people are great both arms for monster dumbbell? They always put their sandbag on alternate shoulders. We don't. So it's just being mindful that there is that bias, and we have to appreciate that it will fatigue. So if you've done sandbag to shoulder, no, it's not pressing, but if you press the next day, you might be very aware that one side is not quite as recovered. So in strongman, it's being very mindful of that. So it's not to say don't do it, but have that appreciation. Write to your coach that I might need overhead on a different day, or we have to get that exposure in a bit differently, because in a competition you can't say, sorry, I need a bit more time, change the events because I'd rather sandbag be after pressing.
I'm pulling the old lady card.
Yeah, well, you never know, masters might get away with it. But no, that's why we get knots, and that's why I was saying about earlier. Sometimes we have to go back to the why. We can release it all we want, but generally it's that strength, and strength takes time. So I think with strength, and Chloe will to clarify more, we're looking at 6 to 8 weeks to notice a big difference in strength changes. It's been something you've had for a long time. It's not a quick fix, but the aim is it's happening less and less, or you're getting a lot more control on it. And that's where that self-check is trying to have a look at, are you in the best position to be doing your session, or how can we make you in the best position, but also factor in your single arm work. So are we making sure lefty for yourself is getting that opportunity to catch up? And that's where that single arm work start on the weaker side and just copy on that stronger side, because the strong one, yes, it won't have as much of a workout, but it doesn't need it because we need to get things back together. Does that answer that question with a lot of babbling?
Yeah, no, it does. Thank you very much. I appreciate it.
Sorry, I'm just seeing Sam. Cosplay have not in micro traps since my next cover. Yep. So yeah, posture is a big thing. So it's, as I said, it's the big picture. What are you doing all day long? Don't blame the gym. And it's stress is a big thing, and that's what a lot of the work I do is linking with pain team. So it's having a look at the psychosocial factors. So having a look at, some people get more shoulder pain or neck pain around exam time, or crunch points at work. So sometimes we might not think, oh, work's not that busy, that's normal, but our body can sometimes react without us having to think, I'm stressed. And as I said, there's no position that you can't do. It's our body is designed to do lots of it. It just doesn't like sustained of anything. Okay, so Panda, oh right, Panda's off. Is there any other questions? Stunned you all. No, perfect. So probably the big take homes is there's nothing you can't do. Always remember that you've got a dominant side, so especially strongman. It will be that's something stronger, and that's where we sometimes have to work a bit harder. But that's where your coaches will be really good. Make sure you're documenting these things. So if you're doing dumbbell work, have a look at just the quality. It's all well and that good that you got it up. Obviously, your videos will show it, but we've all had it where we press and one arm's here and the other one's like, I'm coming. That's the kind of things. Is it happening once? Fine. But if it's happening consistently, what do we need to look at to make sure we're keeping that balance? And also that we're not overloading the stronger side because the other side's not quite pulling its weight. Any other questions? Otherwise, I'll leave you to it. So the presentation's already up on Everfit. Chloe will put this recording on. If there's any questions, as always, message away. But otherwise, have a great weekend or evening. I appreciate a lot of people in afternoons at the minute. But have a good day. See you later.
Thanks very much.
Thanks very
See you guys.
much.
Bye.
Bye.
Bye.